Good morning and welcome to the Endeavor Health Outcomes Research Health Equity plus Implementation Science Seminar Series. Today, we're delighted to have Professor Dezheng from the University of Chicago, who will be presenting his research on treatment declination, racial ethnic disparity, and breast cancer survival. We are also honored to be joined by an expert panel from University of Chicago, as well as Kimberly Richardson, who is the founder of the Black Cancer Collaborative and on the Pecoria Board of Governors, and has a number of other notary honors as a national thought leader on this topic. And Jing-Con Freeman, who is a doctoral candidate at the University of Chicago, will join us on an expert panel. So I'd like to start off and thank everyone working on the front lines in primary care clinics, in their communities, and for all the work that they're doing to fight the good fight towards health equity. And I'd like to thank the program directors and outcomes research staff for the ongoing support of this seminar. So my name is Sean David. I am a family doctor. I also do research in genomics and primary care across a range of areas, and I have a background in public health. Rachel Brewington is the administrator for the Outcomes Research Network at Endeavor Health. She is my partner in the seminar, and we will be working together to bring you through the process. The objective for this seminar series is we want to disseminate research that advances implementation of health equity in our health systems, as well as health equity in our community and policy change to promote equitable care and outcomes, and that also advances translational science, as we're part of a clinical translational science program. And ultimately, when we want to support clinical investigators who are active in this area, promote team science, and really have a network effects across Chicagoland so that we can begin to churn up a lot of great ideas and build new teams and collaborations. So ultimately, we want this work to help improve outcomes in our health systems and across our communities. So the learning objectives for today's seminar are first to provide an overview of the trend of declining of 4 types of breast cancer across the United States, address the social determinants of health related to declining breast cancer treatments by patients, and observations on racial disparities in declining breast cancer treatment and the outcomes long-term on survival. Next slide. So we're part of a CTSA, and so each of these seminars is handpicked in ways that can really identify excellence across these translational science principles. Creativity, innovation, focusing on unmet needs, and generalizable solutions across the nation, cross-disciplinary team science, efficiency and speed, bold, rigorous approaches, and promoting diversity, equity, inclusion, and accessibility, as well as some boundary crossing partnerships. And so we try to model that with our panel to begin to have transdisciplinary conversations with a range of experts. Next slide. Okay, so I'm going to pass this to Rachel. We'll talk about the CME.
Thank you very much, Dr. David, and hello, everybody. To mark your attendance today and claim CME for today's session, text the SMS code in the number listed on the screen. For this live activity, the University of Chicago Pritzker School of Medicine offers a maximum of 1.5 AMA PRA Category 1 credits. Physicians should only claim the credits that match their participation level. Other healthcare professionals will receive a certificate of participation. If you're interested in how these certificates apply for AMA PRA Category 1 credit from ACCME accredited organizations, please check with your professional licensing board. The CME flyer is attached to today's calendar email and will also be emailed to you along with more instructions on how to retrieve your CME credit after the seminar today. During the webinar, you'll be muted, but feel free to ask questions or share comments using the chat function at any time. Remember to consider your audience when posting. And if you have something to contribute to the discussion, make sure to address it to both the panelists and attendees so everyone can participate. Thank you very much, and I'll pass it on to Dr. David.
Thank you, Rachel. So this is an overview of the seminar. We'll start off with our present introduction, and then we'll go right into the presentation from Professor Hua. That presentation will run about 35 minutes. During that time, if you think of questions, you don't need to wait. You can put those right into the comments. And Rachel and I will be keeping track of those at the end of the presentation. We're going to have some Q&A, and Rachel will read back those questions to Professor Hua, and also our panelists are welcome to also help answer those questions. Then we'll introduce the panel a little bit more in depth and have our Incubator Hub expert panel discussion. It's a very rich part of the seminar that I'm really looking forward to today. And then we'll have some closing remarks and information on where to find a video of this seminar and evaluations. Thank you. So without any further ado, it's my honor to welcome Professor Dezheng Hua, who is Professor of Public Health Sciences in Epidemiology and Medicine at the University of Chicago. He's also Professor of Medicine in Department of Medicine at the University of Chicago, and he's a world-renowned cancer epidemiologist who is the lead of this study. So Professor Hua, welcome.
Thanks so much.
Mm-hmm.
Thanks so much for this invitation to present our work in this implemented science seminars. So our work can really do a really transformative in the clinic. Should I start or?
Please do.
Okay. Let me share screen first. Hey. Can you see my screen?
Yes, that's good.
Okay, good. Thank you. So today we present actually a paper we published early this year with title Declination of Treatment, Ratio, and Ethnicity Disparity and Overall Survival in the U.S. Patient with Breast Cancer. And here's my co-authors, Jason, who's in the panels, and James, and the student, Susan, and Kathy, Sin, and from North Shore. So I don't have any conflict interest to disclose. So in the breast cancer is actually the most common cancer type in the female in this country, and the second leading cause of cancer death. And the treatment actually for theoretical treatment of breast cancer now are all evidence-based. So nowadays we actually promote the cancer treatment and using interdisciplinary and multidisciplinary collaboration among clinicians, and we promote effective patient-clinician communication and shared decision makings. So respect patient decision and introduce the treatment to patient in a kind of informative way. So, however, despite the clinician recommendation for treatment and clinical trial based treatment evidence and benefit, but some patients still choose to decline the treatment. And declining treatment could have a detrimental effect on patients' short-term and long-term outcome, as well as their quality of lives. So here research on colorectal cancer, ovarian cancer, lung, and mixed cancer type, they document that if people forgo their recommended treatment, they could have an increased risk of all-cause mortality and disease-specific mortality. So there are several factors already identified, like older age and the racial ethnic minorities, and patients with low socioeconomic status are more likely to refuse treatment. For breast cancer in particularly, pure study report similar factors. However, they mainly focus on chemotherapy and surgery and the treatment decision associated with mortality. But it did not evaluate any pattern of a long-term trend of treatment declaration in the entire country. So they assess the risk disparity, but mainly focus on Black and Hispanic patients, but not in less extent to Asian populations. So there's knowledge. So in other words, they do have a knowledge gap in the literatures. So to fill these natural gaps, so we try to do a study and with following questions. So want to know what's the pattern of treatment declarations among patients with breast cancer in the entire United States, and what are the trends in treatment declarations, and the other treatment across risk disparities, and what are the implications of treatment declaration on overall survivals among patients with breast cancer. So specifically, our primary aim is focused on full treatment, chemotherapy, hormonal treatment, radiation therapy, and surgery. Our second aim is look at the risk disparity on overall survivals in patients with breast cancer stratified by treatment decision. So we use the National Cancer Database from 2004 to 2020. And as you know, the NCDB is a national oncology registrations capture more than 70% of cancer diagnosis from more than 1,500 cancer treatment cancer center or cancer program in the United States. And because the eligibility criteria for the treatment are now for full treatment are now same, so we have we attribute four overlapping cohorts. For chemotherapy, all the invasive breast cancer, stage 1 to 4 are included. For hormonal treatment, we're including all the invasive cancers and who also have a hormonal receptor positive disease. Well, for radiotherapy and surgery, we only include stage 1 to 3 tumors because 3-4 tumors, for them, these two types of treatment are now standard of care. There's still clinical trial debate why they use RT and surgery in stage 4 tumors. So our main outcome is treatment decisions. So in the NCDB, they record why their treatment are received and mistreated, and why they did not take treatment because the patient, their family member, or guardian refused the recommendation from clinicians. And we look at, we count the number of their treatment patients who are eligible and the number of patients who were declined by this patient. So we also have an outcome variable is the overall survival, defined as the date from initial breast cancer diagnosis to date of death of last no patient contact, whichever comes first. So per the NCDB, we know that in a patient diagnosed in 2020, because they have limited time of follow-up, they are not included in the survival analysis. So in the one independent variable, race and ethnicity, we have 5 categories: non-Hispanic, Native Americans, and non-Hispanic, Asian, and Pacific Islanders, non-Hispanic Black, Hispanic, and non-Hispanic White. Those are actually self-reported and recorded in the cancer registration. We also include in age of diagnosis and the year of diagnosis, sex, and health insurance type, income profile in their residency, and the rural urban area. We also look at the facility type And in terms of clinical factor, include the comorbidity index, HCC stage group, histology, molecular subtype, and the tumor grade. So in terms of method, when we look at the trend in treatment declarations, we utilize generalized linear model with log link and binomial distributions, so we can calculate the percent change per year. We use the multivariable logistic regression models to look at factor associated with the treatment refusal. We use Kaplan-Meier analysis and log tests as well as cost models to model the survival of breast cancer patient. So here's the result. The study includes more than 2.8 million patients with mean age of 61.6 years old, and majority of patients, 78% are white, and 1.7% are Native Americans, 3.5% are Asian and Pacific Islanders, and 11% are Black, and 6% are Hispanic. So the majority, about half of them receive they have a private insurance, and 40% receive Medicare. Non-ineligible, 6% receive Medicare. We also have a small proportion of people who are uninsured. So here's the main result. So almost 10% of patients refuse the chemotherapy, and 6% refuse hormonal treatment, and 5% receive, 6% refuse radiation therapy, and 5% refuse hormonal treatment, and only 6% refuse surgeries. You can see that for different type of treatment, the refusal rate is actually quite different. So here's the pattern. So we count the number of therapeutics recommended. Among people who only recommend one treatment with actually surgeries, and also some non-surgeries. So you see like only 1% refused. But among people who recommended all four type of treatment, they are usually stage 3 tumors. So for them, only 84% of them followed all the recommendations, and 0.4% refused all the treatment, and 10% refused one, and about 5% refused 2 or 3 therapeutics. So here's the trend over time in the United States. On the top line is the trend in chemotherapy. You can see that a slightly plateau and the decrease in recent year, with annual decrease of about 1% reductions, and all this trend actually significant. The second line, the orange line, show the result for hormonal therapy. You can see that you see a clear increasing trend, then slightly increase. And the overall trend, you have a 2% increase per year. And the big increase happened for radiation therapies. Increase from about 3% of refusal rate to more than 8%. The annual increase trend is about 5.6% per year. Another thing is for surgery, and also see a big increase over time. Initially, you can see very close to 0.1, 0.2%, but in 2020, they are almost 1%. So the annual increase actually 11% per year. So this is very astounding. So we do not know exactly what's the reason why people refuse all this treatment, and because NCDB do not recall the reason of refusals. But we think for chemotherapy, it could be because because people don't think they have enough benefit. So to test this, and we also hypothesize that if people receive multi-gene testing, they can make a better decisions. So for that reason, we stratify the treatment, the declination of the treatment by Oncotype DX scores. We use the genomic health threshold. You can clearly see that for people now tested, they have a 12% refusal rate. And for people who have low recurrence score, they have 30% refusal rate. Well, for people high recurrence score, they have only 8.7%. In other words, so genetic test is one kind of determining factors for advice, clinician, and also the patient to receive treatment. And well, our patient, they are very knowledgeable. And of course, there are other clinical factors to help decisions. You can see people know, so we don't know why we still recommend this low recurrence score patient for treatment. Of course, there are only 4,000 people. But you can see that the patient actually make decisions themselves. They don't want the treatment because they think their disease is not aggressive enough. And so similarly for memory print, we have similar findings that people not tested, their declining rate in between of people who are low risk and high risk. Suggests that if you do a better genetic testing, so they could make more informative decisions, and eventually they actually can reduce the refusal rate. So here is the result for risk disparity for the 4 type of treatment by the 5 risk and ethnic group. So you on the right hand side, I'm not sure you can see my mouse. Okay, so you can see that for surgery, African, Indian, and Native Americans, Asian Americans, Black, they are more likely to refuse surgeries. Well, for Hispanic, they actually comply to treatment for all 4 types of treatment compared with non-Hispanic or white. You can also see that for chemotherapy, so Native American and Asian and Pacific Islanders, they have a high rate of refusal compared with non-Hispanic white. Well, in contrast, for hormonal treatment, Asian American and Black, they are less likely to refuse compared with non-Hispanic or white. So when we talk about risk disparity, this really depends on treatment type. It's not universally high or low in one particular risk groups. So in this slide, we show for other risk factors correlated with chemotherapies. The color show the magnitude associations, and the dark color shows strong associations, and red color show positive association, means they are more likely to decline. And if you see, so for all these numbers are statistical significant. If not significant, I will leave it blank. So you can clearly see that all the older patient, they more likely to refuse all type of treatment, in particular chemotherapy, radiation therapy, and surgery. While female are more likely to refuse chemotherapy and surgery compared with male. And there's no difference for radiation therapy between female and male. In terms of insurance status, and people with uninsured and Medicare, they more likely to refuse all type of treatment, in particular surgery and radiation therapies. With Medicare, and they are slightly more than the private insurance patient to refuse chemo, hormonal treatment, and radiation therapy, but the difference actually small. Well, you can also see that this median household income as one indicator of our social economic status, they are not really strongly associated with treatment declaration. So similarly, for people living in urban and rural area, they're actually less likely to refuse treatment compared with people who live in a metropolitan area. Well, we can also compare with the type of cancer program. You see that the pattern is not universal actually. So for actually patient treated in the academic centers, they're actually more likely to refuse surgeries compared with other community programs. Well, comorbidity play a role, but not universally across full type treatment. For if they have two and more comorbidities, they actually more likely to refuse chemotherapy and radiation therapies. But if you have one comorbidity, they actually more likely to receive surgery. Well, similarly, the tumor stage have a different impact on treatment decisions. For surgeries, for advanced stage like stage 3, stage 2 compared with stage 1, they are more likely to receive surgery, but they are less likely to receive, they are more likely to refuse surgery, but less likely to refuse chemotherapy and radiation therapies. So these are actually strong associations. And we'll look at the tumor grade. You also found that people have grade 1 tumors. This is actually less aggressive tumors. They are more likely to refuse all 4 types of treatments. So this slide actually show the Kaplan-Meier curve of people who actually declined the treatment. So among people who declined treatment, you still see racial disparities for all these 4 cohorts and all the different assignations. This is the summary we stratified by treatment decisions. On the left-hand side, we show people declined. On the right-hand side, we show people who actually received the treatment. And for chemotherapy, you see that we single out the Black patient. So Black actually still more likely to die compared with non-Hispanic white among people who refused. But the difference actually smaller compared with people who actually received treatment. Similarly, for hormonal treatment, you actually see the difference between Black and white in both people receive and non-receive treatment. And for radiation therapies, we do see racial disparity. The disparity actually smaller for people who declined. For surgery, we don't actually see difference between race, and only the Asian American actually show a difference. But for people receiving treatment, we see a strong racial disparities. You probably also wonder, how about compare people who refuse with people who actually take the treatment? Do they see a difference? Yes, very clear difference. So among the chemotherapy cohort, in the adjusted analysis, people refused have 86% higher risk of dying from breast cancers. And in the hormonal treatment, so refusal actually associated with 56% increase the risk of dying. And radiation therapy refusal associated with a 2-fold increase. And the refused surgery associated with a 3-fold increase. So actually, you may see this benefit or detrimental effect actually stronger than we observe in clinical trial. And because we may still have a variable that we are not collected, so they may have a residual confoundings. But it's clear that refuse treatment do have a detrimental effect on their survivorship. So in this study, we observed the rate of treatment declarations actually higher in chemotherapy and low in surgeries. And we see significant increase in hormonal treatment, radiation therapy and the surgery cohort. In particular, radiation therapy and the surgery is alarming, noted for us. And the decreasing trend in chemotherapy declarations between 2018 and 2020 is probably because more accurate chemotherapy decisions based on genomic acid testing. Further investigation are really needed. So because we don't know the exact reason why people refuse treatment, and so a more study collecting the reason of refuse treatment will be very informative for our finding to be translated in the clinic. So compared with non-Hispanic white patient, Black patients are more likely to decline surgery, and Hispanic patients actually are less likely to refuse all the treatment. And Native American, Asian Pacific Islanders, they are more likely to decline chemotherapy and surgery, but less likely to decline hormonal therapy and compared with white patient. We found older patient, no insurance or Medicare associated with refusal of all type of treatment, but grade 1 is associated with refusal of all type of treatment as well. So advanced tumor stage group, they associated with lower odds of refusal chemo and hormonal treatment, but higher odds of surgery and radiation therapy. So people who refuse the treatment have worse survivals than people who actually receive. But we can not control for all the confounding factors. So there are result difference even among people who decline the treatment. But in general, the magnitude of difference are smaller than people who actually receive the treatment. So in conclusion, we found there are pretty high refusal for chemotherapies, and so we hope this data can be helpful for future discussion between patient and clinician. So our study do have limitations, and we have unmeasured confounding factors, and so we do not collect information about why the treatment or why the people sought second opinions. So one limiting we have is all the data we have is the first course treatment. They may receive treatment later, but we do not know. Usually the first course treatment collecting registration is within the first year of the cancer diagnosis. So the patient cohort may not be representative, and but we do find that our findings are consistent with a SEER population-based study result. So we present our result in San Antonio last December, and our paper published in May in JAMA Network Opens. And we sunk the findings of the studies and found to have no rules in our conduct of studies. Thank you very much for your attention. Okay. See, I'm still on time.
Yes, that was brilliant presentation and great work. Rachel Brewington is going to read some questions that were put into the comment section.
Yes. 1 second. Okay, here's our first question. Do you have demographic data on who did or did not receive a multi-gene panel on their tumor?
Yes. We do have a demographic information on those patients, yes. Yeah.
Okay, and another question was to ask if data on reasons for declination were available.
Right.
No, so for the reason,
No,
that's
not
not only
available.
Yeah, that's one of the limitations using the national cancer database. So they don't collect the reasons why patient decline any of the treatments. That's one of the limitations. Yes.
Yeah.
Okay.
Yeah.
But we do see,
yeah.
but we do see, some socioeconomic, sort of indicators, right? So that could be some of the reasons, but exact reason we don't know because they don't collect the data, unfortunately. So
Yeah, so probably clearly that age may be a reason, definitely. Insurance status and the type of tumor, tumor grade, and the tumor stage, they are pretty strong predictors. If we don't ask, we probably these are actually important reasons. And in terms of first question, actually we look at the people receive uh, demographic information and the recent disparity in oncotype DS receiving, and we found they do have racial disparities. And the good thing is once they receive the oncotype DS testing, in terms of the treatment, we don't see a difference. So it's actually access to the testing actually more important in that aspect.
Okay, thank you. Next question. Is there a difference when the provider and the patient have the same race and or ethnicity?
We do not know the information about providers actually. So this is actually confidential information in NCDB. So we actually do not know which hospital they come from.
Hmm.
Yeah.
Okay, thank you. Next question. How can we confirm that patients were offered the treatment?
This is actually recorded by cancer registrations, and I think if we see yes, more likely yes, the cancer registers they collect information from electronic health record from clinical note, so they know at least for chemotherapy and surgery and the radiation therapy that's pretty I was thinking accurate, but for hormonal treatment. May not be accurate as we think. So people may forego some treatment as they recommend for 5 years or 10 years, but people maybe actually stop early. That's a good question. Thank you.
Sure. And our last question here is from Dr. David. How was declination accepted treatment ascertained in the registry? Was there a patient questionnaire or ICD code structured data?
No, this is also from based on registers. They actually look at the chart and they check whether they actually offer treatment and the patient said no. I think as a clinician, I'm not clinician actually. I talked with clinician. They told me that they usually record that because for financial reasons, they offer treatment, people refuse. They actually document that. But we do have missing data. Basically, we do have a pretty large proportions, and up to 5% of people they do not receive treatment, but they don't have classification. This is because the people refuse, or because other reason they did not mention that. For those cases, actually we excluded from analysis, and so we only if they have a clear definition, we include in the analysis.
Thank you.
Okay.
As of right now, that's our last question in the chat. If anybody has any other questions, please post them now. Okay. All right, Dr. David, I can hand it over to you now.
Thank you.
To introduce our panelists.
Wonderful. Thank you, Rachel. Thank you, Professor, for a wonderful talk. I would now like to introduce our expert panel. Dr. Susan Fisher, Healthcare Delivery Sciences Vice President, Director of Outcomes Research, Head of Family Medical matter to deal with today, is unable to join us. She sends regrets. Also like to introduce Jing Freeman, who is a doctoral candidate at the University of Chicago under the mentorship of Professor Hua in the Department of Health Sciences. And he's also a graduate trainee in the Cancer Health Equity Training Program, T32, postdoctoral fellow. I assume this will go into your dissertation and you'll get that PhD, no problem. And we're honored to be welcome to be joined by Kimberly Richardson, who is a two-time cancer survivor, advocate, founder of the Black Cancer Collaborative, a 501c, and she's on the governing board of PCORI and a number of NIH Institute review panels. So we are honored to have our expert panel, as well as Professor Hua, join us. And so why don't we go to the next slide? Very good. So watching this presentation, some of the data on survival mortality differences were really jarring to me. And it made me think about how would we implement this research in a clinical setting. So what are the health equity to advance health equity in our health systems? And it seems to me that there's a lot of questions about reasons for declination. If the data are ascertained from chart reviews, so are there implicit biases in that process? And reasons beyond this in terms of addressing communication strategies. But what I'd like the panel to address is, can we use this kind of information in shared decision-making with patients up front to reduce declination due to reasons we don't know in some cases? Like, how do we translate this into our health systems? And where do we go next? So any thoughts from the panel? Do you think, for example, that sharing information on declination and survival is appropriate at this stage? Would it be ethical not to? And how do we address this complex issue? Kimberly, what are your thoughts?
Sure. I was startled by the fact that this was such a sort of a binary scenario. Do you want treatment? Yes or no? No? Okay, see you. And I don't want to be so blank about it, but it just seems as if there's some nuances between that yes or no question. It's some multiple choice kind of responses, I think, are playing a huge factor here. When I think about sort of our usual go-to narratives, right, about medical mistrust, that narrative has been around for a while, but how can we use some information about medical mistrust to create better implementation strategies to reduce people saying no to chemo or to radiation? And so I think about a variety of things, and I think we're going to have that rich discussion about all of these things. But when I ask myself about medical mistrust, the first thing comes to mind is a person is going to say, am I going to get the same standard of care? Am I going to get the same quality of care? Right? Because of this deep-rooted mistrust of the healthcare system. I think about, of course, other narratives around insurance and inabilities to do the treatment, to be able to sit for 2 to 3, 4 hours to take a chemo treatment over a 6-round period of time. Have we factored in what that means to that person's employment status? I think about those are some of the the usual narratives. And it seems to me that, we need to be connecting those usual reasons to improving our supportive systems. But then there's some more deeper and more personal kinds of reasons as to why an individual would decline treatment. I think about things like spiritual beliefs, right? Many people tend to think, that their faith is going to get them through, that there's going to be this supernatural healing, right? And for many in the science sector, that just sounds ridiculous. But that's a very strong, deep-rooted belief. And what are we doing to create a supportive service for those individuals that do have those belief systems? So I'm thinking about a lot of different reasons as to why someone would decline, right? But we also have to look at that yes/no question. How was that question addressed?
Mhm.
How was that person asked information? So it's a lot of how much information was that person given? How well did they have a comprehensive care team? Not only just the oncologist, but the radiologist explaining the radiation, the chemo nurses explaining what chemo would look like. And then, of course, and last and most importantly, that personal reason is connected to genetics. Perhaps someone in their family suffered greatly from breast cancer. And they're just saying,
Yeah.
I see what it did to them. No, thank you. So those are some of the first thoughts that come to mind, Dave, Sean.
Thank you so much. And I just want to emphasize that I think the onus is on the health system to figure this out, not the other way around. And these conversations are really difficult during a scary time with a lot of uncertainty and limited information. A patient can possibly, stimulate all of that, and in the way I think it's if it's not communicated, and if people don't hear those stories. So I'm really, think this is an area of research that we could really develop and try to better understand how to do the shared decision making in ways that is bidirectional. So these decisions are anyway. But I want to ask other members, Jason, your thoughts on this issue.
Yeah.
I'm sure this has come up to you, right, in your San Antonio, and what were clinicians saying about this?
Yeah, so thank you, Kimberly, for bringing a great point, and then so the nuances, right? So the data says, does not capture, right? So we just, it's part of limitation that we acknowledge in our study. But at the same time, but we do see some socioeconomic status, right? That really doesn't, have an impact on really declining those treatments, which just makes sense. Even, so for example, clinical shadowing with, our medical oncologists in clinics. So we do have some patients where they're Hispanic or they're Black and brown patients, some lower socioeconomic status. But I think, I guess I can see, from Chicago, I guess, from the clinic in terms of so how can we, help, patients navigate, right? So sort of financially. So that's why, so they do have some patient navigation program where, can really help to address those problems. But sometimes I think is that enough, right? So because like you said, some of the social factors, some other personal, reasons, or could be also medical mistrust could be a really important, a critical, factors. I'm going to bring out a case study, because you put a great point, right? Because in, the minority, the medical mistrust is really significant, factor. So I can speak a little bit to that. Just recently, I was, consulted with a patient. He's a Black, mid-60, but the mammo detected is early stage, has a less than 10 millimeter tumor, undetected, two negative breast cancer. As we know, it's a type of aggressive breast cancer. So she caught early. That's great news, right? Because usually in terms of standard of treatment, so you're gonna have upfront sort of surgery. You're gonna have a lumpectomy, but if you have a lumpectomy, we'll follow a radiation therapy, and then we'll plus chemotherapy. Also depends on the tumor size. But if you have a mastectomy, you're also gonna follow the chemo because you can avoid the radiation therapy. So when I and the fellow, because usually they have oncology fellow following oncologist. So we create the cases and then we went into the patient. So just sort of had so the fellow, so her name's Ashley, so it's a black student, so she's amazing, she's great. I really enjoyed chatting with her. So we walked in the room, so this patient, so we just decline anything. Like so she met a surgeon before coming to our medical oncology. So she was telling Ashley, I was sitting, sort of engaging sort of kind of conversation. So she was telling Ashley about I'm not getting surgery. I don't want, the white surgeon open my breast. That was her sort of, just coming out of, that's what she was telling us. And then because, like, oh, I don't really trust, you know, uh, uh, you know, uh, the health system. My husband was in Savannah, Georgia. I got, heart problems, but I have open heart surgery and then just die a few days later. That's one of I think so. I think it's hard, disheartening, right? Because it's see your loved ones, pass because of what the killer received, right? So, but also at the same time, there's a lot going on with her as well. So she's still working, as a clinic company, but then she has, she cannot take time off work for either surgery or for even chemo, right? That's what she also pointed out. So, but actually, and I was sort of engaging with a patient, like, yeah, we understand, of course, from the socioeconomic factors, so that's back because we try to sort of giving giving her, I guess, like, don't worry about, we have patient navigator program, we'll try to help you financially through. But now she also bring another point where some social family problems where so she recently, purchased houses moving in 7 months. And then there's a sort of family dynamics going on. And she was pointing out where, like, yeah, my daughter wants me to have surgery. My daughter wants me to have chemo, but I think, my daughter wants me to die early so they can have my house. So there's a lot of, things going on, right? So it's how can we, as a physician, how can we address those at the same time, right? So that's why, I think I guess from my perspective, from what I understand from patients, that the medical mistrust, I think is number one sort of, factor that how can we really, speak with the patient? How can we, make understand that this is aggressive disease, but we caught early that it's pretty treatable, right? But how can we get through that barrier, the medical mistrust? I think I don't have an answer to that, to be honest. But here's interesting though, because Ashley, again, so they're both are black, right? So this seems to actually try to really talk to her and about, how important the treatment is. This is standard of care. Wherever you go, and you will get the same thing because it's standard. And I hear you also really resonate with her, how this I think may play a role because seems her tone sort of, slowly like, oh, I will think about it, I'll consider it, and then but I still need, some time. I just can't. It's just a lot of things going on. So I think it's no, I guess there's no sort of one way of approach, right? Because you need to address some of the financial part because she cannot take time off work and have to address some of the social family network you need to bring to sort of clinical social work. That's what, so it's a very important part of, team, right? So the multidisciplinary, that how can we help them? And also, again, patient education, right? Through the oncologist standpoint, or even for a patient education program, that how can we really to get through the barrier, medical mistrust barrier, and how can we really help engage the patient and into the care. So, but also, of course, is as Kimberly was mentioned, that some of the personal reasons, and it's no binary, right? Yes or no, decline or receive.
Yeah.
But
Yeah.
but I think there's a lot of things where we need to consider, but also we also point out whether and so nowadays, right? So you basically can see any oncologist get a consultation and they can go to see another one or another, even a third consultation, right? So those are not really captured too, because sometimes, like you said, right? If I'm seeing a patient that with the same race, ethnicity background, they might probably, more likely, sort of having more engagement, maybe more likely to to receive the treatment at that, the clinic or facility, right? That's it's possible. but we don't have that, sort of data in this national database registry, so which is, part of the limitations. But yeah, just going back, I guess, just how can we address this through sort of a multi-level or, factors? So how can we address, do we
Yeah.
address at the same time, or, we can, try to identify what is, the significant factor that we could address first. In this case, a patient case study that I think we should sort of, how can we educate patient, get through this, medical mistrust barrier, and then we can work with, patient navigation, work with the clinical social work and some social factors, right? So that could, really work well. So I think that's great. So how can we really include, implement this, and then how can we improve this, from the health equity lens in the healthcare system, also put it in maybe in breast oncology. In my case, then we do need to have a multidisciplinary team, and also work with patients, and then how can we get through the barriers? I think that's one of the things that we could implement that. So, but I think through one of my observation, I guess also my experience at U Chicago, so they do work pretty good, with patient, to do some of the informations, right? So also Kimberly was pointing out, the chemo, right? So they do have some of the education, and also the print out some of the studies or clinical trial that patient can take home to consider, right? So that could also play a role in terms of my goal about not doing this or go to alternative, right? So, and then we also discuss about the medical oncologist, like if the patient don't want to do the surgery first, and we can do some neoadjuvant setting, right? We can try to do some do a short-term neoadjuvant chemo to see how the tumor responds, and then we can walk with the patient, if the patient decided to get with us. So
Yeah. Jason, thank you for sharing that anecdote. And it's really heartbreaking that what I heard, but also there's so many anecdotes that are heartbreaking in this story. And it would just, like to hear some reactions. Kimberly, Dezheng, to
Yes,
what you
yes.
heard there. Yeah.
Yeah, and Sean, I had the exact opposite reaction to what Jason was sharing, that you actually had a patient that was talking. That was giving you some clues to how they could be influenced towards going toward treatment, right? It's the ones who say no and close down and don't share that make me very nervous. All of the things that in Jason's anecdote showed that this was someone who just needed someone to listen and someone in her space to seem like they cared, right? She gave you all these instances where she felt family wasn't supportive. And now she's dealing with what she thinks is a life-threatening disease. And it's our responsibility, both patient advocates as well as providers, to let her know stage 0, stage 1, 95% progression free. If you do chemo, if you do radiation, if you do the maintenance treatments, right? So what you're dealing with everyone, whether they speak up or they don't, it's fear, right? And so how well is the oncology education part of this system really dealing with the fear? Because I sit as a public member for ACGME and for the graduate education piece of this, and I look at the mock conversations that the doctors have with patients, and it's already assumed you're in shock, you're not listening, and so it's all these really interesting ways in which we transfer knowledge to a patient who's just been recently diagnosed. And how many times do we say it, right? And how many times do we say it to their loved ones, right? And then how many times did the team say it, right? I like to share my anecdote. I was stage 0 for breast cancer, stage 3 for ovarian cancer. Totally different diagnosis, totally different treatment, totally different way I was treated. But what I love to share is the concept around uh, the radiation. I got the opportunity only as a patient advocate to know that I could have accelerated partial radiation as opposed to sitting through 33 consecutive radiation treatments. There was nobody in that space that helped me make that choice. It was only because I was a patient advocate that I knew to look for it in PubMed. I look for the new treatments and the research that was being done on treatments. But the interesting part of that was when I brought it back to my oncologist, her response to me was, for every research study that you find, Kimberly, that says that's a good thing, I can find a research study that says that's a bad thing. So there's a disconnect, I think, sometimes between the oncologists and researchers, right? It's like what works, what's standard, what's best, what's easy for me to explain to a potential patient. Maybe I don't know, but it just seemed to me in my situation, right? By the time I decided, well, I'm going to blow off this oncologist, they don't know what they're talking about. I'm going to have a conversation with this radiologist. And when I brought up accelerated partial radiation, absolutely. Why would you want to do 33 consecutive radiation treatments and come into this hospital for 33 treatments when we can give you 5 over 2 weeks? Absolutely. He was very much, he understood the research. He was very much up on it. But I asked him after that, I said, this seems so bittersweet to me because will you tell the next Black woman that she could get accelerated partial radiation treatment? Or will you just go along to get along? Because the oncologist sent her in here with this referral. So those are the kinds of things when we talk about disparities, when we talk about how treatments are communicated to patients, that we really need to look at those nuances. And I don't think sometimes that the data will bear those kinds of situations out.
Thank you so much. And I had another comment come in about how do we educate the clinician, the whole health system? Like this is a big GME and maybe earlier on issue, but we need to do better. So how do we, as an educator, Professor Hua, how do we address this at the cancer center level? Because I know you're involved with a lot of detailing there.
That's a good question. So I will continue Kimberly's discussion actually. So actually from the current data, we show that if you see a heavy burden of treatment and patient more likely to refuse. And we have a higher level with full type treatment. We also have another level like radiation therapy, how many fraction you gave them, how many days you should go. This is actually also important. So we actually learned that for now, take another example, for Herceptin treatment, the standard of care is 1 year of treatment, but new evidence show that half a year can still do the job, can still save people life. So this actually, for financial reason in developing countries, because the treatment the drug is expensive, they try to reduce the dose to see whether you could have same benefit. The results show up, yes, you can have same benefit. So I think in medical field, we try to add more and more treatment, but on the other hand, we should think about what's the financial burden, what's the barrier. So they have to go to work. They cannot they cannot treating disease as occupation. They come in hospital every day. So I think that's the thing we need from system level is to think about how to reduce the burden of treatment. And another thing is you can see that for the refusal is high in radiation therapy, increase, and also pretty high, almost 1 out of 10 in chemotherapy, because the side effect that patient they heard from the internet, from their relative, they say, oh, the chemotherapy is really have a lot of detrimental effect on my quality of life. So from system levels, we need to provide better supportive care for this side effect. And so we need to reduce the fear of this, this side effect. A lot of side effects can be controlled in chemotherapy, actually. So nowadays, and people have hair loss, and new research showing that their medication can prevent your hair loss. And so a lot of supportive care, I think, is important in addition to this curative treatment.
Yeah. Thank you. I also, wanted to move to the next question about how to implement results to advance health equity in our community. And I guess I'd like to restate this as how do we better listen? Not how do patients better listen, but how do we better listen so we have those opportunities to empathize and to learn how to meet patients where they are, and with cultural humility and respect. And so this next step, I'm thinking we can't get the answers inside the health system to be better about this, that we need to listen to the community and engage as partners. So I know, Kimberly, you've done a lot of advocacy work, and your thoughts about this in particular would be really helpful. Is if you're talking to Mr. and Mrs. Health System, what do they need to hear to, get started on doing better about this? And I think you probably can refer to some resources, but
Sure.
I think, yeah.
Well, I think the first thing I always think about, which always bewilders me, is there's the business side of care. And we have survivors that have gone through treatment and they've rung a bell and they were like, see you later, bye-bye. We'll see you maybe 3 months from now. We'll see you maybe 6 months from now, and eventually a year from now. And then we struggle, we being the oncologists and providers in the system, they struggle with how do we connect to the community? Now, your community was the patient. This is a person that was in your care for 6 weeks of chemo, for 33 consecutive treatments of radiation, for 5 years of maintenance treatment, and you haven't connected the dot that that's your best ambassador to the community to talk about this institution saved my life. This institution knows what they're doing.
The community came to you. Yeah, the community came to you, and you didn't talk to the community.
Yeah, it's like that to me is such a no-brainer. It's like if you're going to follow the business model, right? Testimonials, we are your biggest Yelp, right? Depending on what our relationship was with the chemo nurse or the radiologist, or with anyone who took our temperature through the entire process, right? We are the first people that can give you the best testimonial of how well you care for Black people if those people are talking to the community about the importance of having relationships and reducing this sort of medical mistrust.
It starts at the front door.
Right. I mean, we need to be realistic.
Yeah.
Sean, we need to be realistic. We're not going to get enough Black oncologists through the pipeline to say, oh, we need more representation. We got to deal with what we got, right? And so you're right. There needs to be some training. There needs to be a part of board examinations that these soft skills are just as important as being able to do an incubation.
Absolutely. So, I think from the policy standpoint, you've spoken at Academy Health and a lot of different forums about policy. What are some places to go next with policy to support equitable care. And I think we talk about things that social sciences as soft sciences, but in some ways there's some hard data on things like climate, emotional intelligence, EQ, that kind of thing, and outcomes. And so how do we better? What policies do you think would reinforce the type of culture change we need in our health systems?
Any policy change that really looks at the structural barriers within academia. Any structural barriers that look beyond academia to research. And so that we're looking at how we educate the practitioner, and we're looking at how we are educating the researcher as it relates to patient and community engagement, and the importance of having that missing piece at the very beginning of a research protocol and at the very beginning of when medical students are being taught. We're not an afterthought. We are the reason why you're in this, where you get to wear the white coat and why you're in the lab. And I'm not really big on, research, nothing without us, nothing about us without it. I'm not really about slogans. I'm really about looking at what are the things that we talk about in terms of research, right? What do we look at in terms of what is the problem? But we're not really looking at how the problem began in the first place. And it's never with the patient. It's always with the structural barrier, the structure, should I say, of how one learns, and then how one practices, and then how one does research. So it's like garbage in, garbage out. If you're not going to teach about the value add of listening to the patient, if you're not going to think that the patient can impact all levels of the drug development cycle, then you're going to get providers as well as researchers who have sort of a I know it all opinion about the work that they do every day.
Yeah.
It's inevitable.
So this goes back early, like really identifying character and sense of justice and a sense of love for humanity that they want to capture early, to find people who are committed to those values, I would think. But I'm guessing that we're not testing in MCATs and things like that some of the qualities that are so important. So
I'm almost sure that a medical student and a cancer trainee get in this game because of the altruistic properties of the work that they're doing. But I can almost guarantee you it gets sort of beat out of them before they get to the point of practice.
Yeah, it's so true.
Thank you, Kimberly and Sean. So I totally agree. So from the healthcare system, from the provider standpoint, so I think again, so is it sufficient enough, right? So I think if you look in the community wise, right? So from a lot of qualitative study, that we do need to go into the community, as community was saying, right? We listen to the patient individually, but also the community. So we do have problems, and we do know the problems are, for example, mortality, right? The disparities that we're seeing, for example, right? Or any other problems. But I think, what the community needs. So I think we do need some, really work with communities to see a needs assessment, right? Maybe the communities in the south side of Chicago may be different than the other, communities, right? For example. So I think, that whenever there's problems, how can we know to assess whether there's problems and needs in the community, and how can we better sort of inform the clinical practice and also policy changes, right? Because it's all community-based, right? Because we want to improve, the quality of life and survival and outcomes in the communities. So I think there's some sort of disconnection, sort of in terms of, like Kimberly was pointing out, in terms of, the healthcare system, some of research, also community and then population-wise, right? So I think how can we really bridging that? I think there's still a lot of, to work, of course, on, sort of, the healthcare system and institutions wise, right? So the structural, the how can we address those? But I think, we still need to, address some of the community needs and how can we really inform sort of policy changes, because we can just, have a problem and bring in the community and say, hey, this is what we think, then we need to do this. But we need to hear the voice of community and the individuals. So that's, I think, so I'm saying like how can we prioritize those, I guess, problems, and how can we assess and how can we really address those? Because we cannot, again, we cannot address all the problems at the same time, right? But how can we really need what's the most needs in the communities and in the patient population, and how can we address that in a clinical setting? Also, how to inform, state and the federal level, policy changes. I think that's sort of going about. So
yeah, I mean, I think the PCORI has a process, right, Kimberly, where that there's a community assessment in the front end that's taken very seriously in the review process. So there's a policy in the sense that work is funded and these programs can move forward. But it seems that approach could be ubiquitous to a whole range of other things too, in terms of how do you reinforce community citizenship in the people that we bring in? How do you reinforce humility and listening and acting in ways that give patients a chance to process and have some sense of context for how to do it right. There's just so many things at a universal level that need to happen, but if AAMC and if the boards and if everyone's on the same, has some policies in place that are more than just platitudes, but actually reinforce this and fund it. It seems like that there's got to be, how we take it on.
I agree.
So,
and it cannot be grant driven.
Yeah, no, that's too late.
It has to be general operating funds investing in that. It can't just be, oh, let's apply for this grant for some CHWs to do some early screening for breast cancer patients. And then when that grant runs out, those are now there are, 3 or 4 community health workers that are suddenly unemployed.
Right. I think, in the balance sheet of businesses, they have this one asset called goodwill. They don't really, but goodwill is donating to things but maybe there needs to be another one for whatever we call this that needs to happen. So it's an investment in value. So then to translational science, one of our researchers, Dr. Jensen, commented that this is a ripe area for work trying to understand the what's really going on with the binary declination kind of process measure, if you will, because as you say, it's not that simple. It's really, there's a lot that goes into this, and that it's not the patient's fault. It's not the patient's responsibility to know that, to get educated. It's our responsibility. I think that, Jason, you listened to that patient encounter and learned a lot from it, and you're early in your career. But so I guess in terms of translational science, ideas for studies that we need as a next logical step. Professor, where would you go next with this? Would you bring in some mixed methods? Would you use the community-based research network to do some town halls and help us?
Well, I have to admit that I'm not really implemental science researchers. I do look at etiology and look at the method, how to improve the treatment, but I'm not really do a lot of research to how to translate to the clinic, to the community. But I do hope that Jason, the next generations of researchers can do this better. Because the problem, we do have a lot of knowledge that generated by researchers, but they're not really used.
I was able to do this design thinking boot camp at Stanford earlier this year. It's like 4 days, and they bring you into Silicon Valley and have these different scenarios where you talk to people. And but the idea of ideating and then diverging on the problem first, and then talking to people who have experienced this in their life, and then converging on the problem. What is the real problem, the root cause problem? And then the next step, then it becomes diverging on the solution. So really open mind, broad, every idea you can think of, big portfolio of ideas, talking to people, piloting, doing prototypes, things like that. And then converging on a solution. So that process has been very effective in the kind of tech world, right? But in the humanity world of how do we do better with people, that
I think one
it seems like we need to diverge on the problem a little bit
Yeah.
before we know what to converge on it. If that makes any sense.
So first thing come to my mind is we really need to engage people who already refused the first kind of treatment to see why whether that can convert them back to accept the stipulated treatment and know the reason for that. And each person have their own reasons. It may be mistrust, and maybe because fear of the side effect or fear of the loss of job or commitment for treatment. Everything are different, but or maybe they think they're too old. I don't need a treatment, for example. I'm 75. I don't need a treatment. So I think we need to single out the individual reasons for each person who refused. If we can convert them back to treatment, that's I think is quite important.
Yeah, I think, because this is given a national trend, given, some of the, patterns that we see and the trend that we see. But again, right, so as Kimberly says, we don't know the personal issues and the reason behind it, right? So going back, also Sean, you mentioned mixed methods, right? So we could, potentially do some, qualitative study, right? Interview the patients, for example, locally to see, what, the reasons, right? So if we decline, for example, I already have a case study, right? Then we know the mistrust is probably the significant factor, right? And also following some of the socioeconomic and also family, sort of dynamic issues, right? So for example, then I think, again, so back to, individual, right? So also in this, we call it, personalized medicine or precision medicine, but not from, genetic genomic and then, medical, but also can be, the treatment, right? So in terms of, how we do that, it's just really based on, each person, right? But I think, also another concern, I guess, because given that, the healthcare system burden, so how can we really, sort of utilizing, what's, sort of, infrastructure available? How can we really convert it and how can we help with that? So I think that could be in a sort of from, I guess, barrier in terms of implementing, all kinds of, I guess, our studies or any kind of study, right?
Well, they're building that big pavilion, new cancer center at the University of Chicago. So this kind of thinking and the design stage as that goes up, I hope it's really been informed by the community because hopefully that will be a different patient experience. And but I think this is a big challenge, but a very noble one to pursue. And I hope that we can partner more in these kinds of things in the future. There's a lot of people who've been sending comments that they'd like to get involved with some of these next step of research. So I'm really encouraged by that. This has been a very rich discussion, and I've learned a lot from all of you. I really appreciate the time you've taken and all the hard work that's gone into this and to your whole careers. I'd like to take this moment to thank the speakers, the panelists. You've all been great. And I keep saying this is the best seminar yet, but it's really true. And I know we're getting to the heart of the research, looking at hard numbers, wicked problems, and big challenges. And I think that I have hope that, but the more we talk about these issues, the more we can begin to at least converge on some solutions. So thank you so much. My email is listed on the last slide, or on this slide here. If you have any questions, comments, concerns, requests, there's an evaluation, and Rachel will send out an email with a link to the evaluation. We really would love to have your feedback and your comments on how to make this even better. And then this session has been recorded, and a recording of the seminar will be distributed to attendees shortly. It's also on our YouTube channel. So there is a portfolio of these seminars going back 4 years. Great resource, I think, for education, for trainings at all levels. And so I want to just thank you again and say that our next seminar series will also be on the third Tuesday in November, and it will be on long-term outcomes of juvenile detention, research that's being presented from Northwestern University. That's going to be, another exciting talk, but also hopefully we can have a good panel discussion as well. So thank you all very much. And then for additional questions, you can also reach out to Professor Hua. I think his email is in the slides. So thank you. Any final comments from the group before we adjourn?
It's a really good discussion. Thanks so much.
Yeah.
Yes,
It's
indeed.
really
Thank
good.
you for having me.
Thank you for inviting me too.
Thank you. The honor is all mine. And thank you so much. Okay.
Kimberly,
All right.
may I talk with you more? Maybe set up meetings.
Absolutely. Absolutely.
Thank you.
Okay.